Good morning. I'm very pleased to be here today to address this issue of the optimizing clinical outcomes in type 1 diabetes from insulin strategies to adjunctive therapies. I'm very sorry not to be there with you, but I hope that will be another time I can see you and met many people from Turkey. We might collaborate for just a long time. And thank you for the invitation to Professor Mustafa. Now, I'm going to discuss type 1 diabetes and the clinical outcomes in the light of new progress. Now, as I mentioned in the other lecture, type 1 diabetes is a very heterogeneous disease. And as you can see in these slides, there are at least 8, 9 factors that can explain such differences. From the risk of progression rate that varies between children and adults, the environmental factors, that the genetic, the HLA that may be different between young people and people with onset in adult age, the age of onset that is throughout life, and this is an important concept to keep in mind. Type 1 diabetes is not a disease of the childhood only, it's also a disease of the adult. And then the histopathology, the residual C-peptide function, and the metabolic characteristics of patients have also an important role in the progression of the disease, and of course, the clinical feature. As I mentioned in my other lecture, we introduced this new vision of type 1 diabetes based on endotypes. Basically, there are different endotypes that reflect different pathogenic mechanisms in the progression towards diabetes. And one of the most important factors is age of onset, where we have type 1 diabetes diagnosed very early in life, and then later on in life, that is actually including type 4 and type 5, that is LADA. And then the genetic susceptibility based on HLA, that is very high, strong genetic susceptibility in the first type 1 and type 2, that means in pubertal and around puberty. The immunological factors, there are more autoantibodies in the very young compared to the adults, and the C-peptide level, as evidence of residual beta cell function, is low at diagnosis in the very young and tend to be higher later on. And the BMI, another relevant factor regarding the heterogeneity, you see that the BMI is normal or low in diabetes diagnosed in type 1 and type 2, whereas is not so low, and you may have an increase in body weight up to obesity. Now, what can we do today with the new development in therapies for optimizing the clinical outcome in type 1 diabetes? We have new insulin strategies, and this is a major step forward over the past few years. And remember that insulin was discovered in 1923, and after 102 years since its discovery, we now have a weekly insulin for our patients. Now, the development of weekly insulin certainly improved acceptance of treatment, adherence to therapy, satisfaction for patients, and quality of life. There are two weekly insulin available, the icodec and the Fcisora, which are produced by the two major companies in the field, Novo and Lilly. And as you can see, the main difference is basically the fact that the injections are now given weekly and not daily. So the patient's adherence definitely has improved, the patient burden, the glycemic control can be managed pretty well with less potential risk of hypoglycemia. The patient's adherence is another important factor that works well, and the patient burden, that 52 basal insulin injection a year compared to over 300 if you take insulin every day. If we look at the basis for weekly insulin therapies and the evolving evidence, as you can see, all the different insulin here have a different profile, and you know pretty well about this profile of the rapid insulin and the slow reacting insulin for 24 hours. And here is the profile of the weekly insulin. And so the weekly insulin can keep your blood glucose, the basal rate of your blood glucose, pretty good, as you can see from other slides. In this review by Julia Rosenstock, you have very good information regarding overall how weekly insulin has been tested and how that can improve quality of life and metabolic control in patients with diabetes. Now, who are the group of patients with diabetes who could benefit from weekly insulin treatment? That is an important concept. Now, once weekly definitely has a more appealing option due to fewer injection. Then we have a reduction on HbA1c that was superior with weekly insulin versus daily insulin. Once weekly insulin provides low risk of hypoglycemia with adequate glycemic control, and the patient that definitely need improved adherence have fewer injection, and of course that could increase the adherence of patient to treatment. And overall, as I can show you in the next few slides, this treatment can lead to improved glycemic control and better health outcome. This is the results looking at the once weekly insulin icodec versus daily insulin degludec as part of a basal bolus regimen in type 1 diabetes. This is the Onward 6 study, one of the most important studies with this weekly insulin icodec. Was a phase 3A randomized open label treat to target, was published in the Lancet, and as you can see, how the icodec does in this patient compared to degludec insulin. And so you have the results here in terms of fasting blood glucose, and this is the glycated hemoglobin. So I think that these results are really encouraging and show that the icodec could really do well in terms of management of patients with type 1 diabetes that are treated with insulin injection and not with the pump. The other insulin weekly is the efsitora, that is, again, a weekly insulin, and was compared in the QUINT-5 study in patients with type 1 diabetes as well. This is a phase 3 randomized non-inferiority trial. And you can see the HbA1c here between the two group of patients. Really, they are equals. There is no difference between the once weekly insulin efsitora versus standard therapy daily with insulin in patients with type 1 diabetes. And then this is the change from baseline of glycated hemoglobin. And as you can see, there are no difference, more or less they are the same. The glycated hemoglobin is 6.9 in patients with the efsitora, and with degludec is 7.5. 7.05, sorry. So that means they're really the same. Another interesting evaluation in the QUINT-5 study was to look at the continuous glucose timing glucose range at week 26 and 52. Of treatment. So these patients were treated for 1 year. And as you can see, the time in range, the time below range, and the time above range are very similar between the two insulins, suggesting that indeed this insulin could be given safely to patients with type 1 diabetes to obtain an optimized metabolic control. I think that another concept that we need to take into account is the clinical outcome with adjunctive therapies. What can we give to patients with type 1 diabetes to improve overall their disease in terms of disease progression, prevention of complications? Are they adjunctive therapies available? Because if you think about the type 1 diabetic patient, you think insulin. You don't think about something else. You just say patient has diabetes type 1 because there's no insulin production, so you take insulin for the rest of your life. Can you somehow modify a little bit this concept in terms of see whether we can give something more to these patients? Now, again, we go to the impact of heterogeneity on type 1 diabetes therapy. So there are a number of conditions could be taken into account in terms of immunomodulation, as I mentioned also in my other lectures. Now, the fact is that the source of heterogeneity could define the type of immunomodulatory drug that you're going to give, whether you intervene on the cytotoxic T cells, how you intervene on these cells, how you could favor a protective effect on beta cells. And here again, as you can see in this very nice paper that was just published in Dermatologia by Ivar Molinos and my good friend David Leslie, you see that all factors that are taken into account are listed here. There are many differential conditions that you have to keep into account, mainly the phenotype, the characteristics of the patient in terms of body weight, if the patients are obese as well, because as I told you, patients with type 1 diabetes may be slightly overweight up to obese. So the demographic, age, and sex could be taken into account. There are also factors related to donor. So that is when we look at the type of transplantation for beta cell replacement therapy, you have a number of potential new therapies available in terms of protecting the beta cell from rejection. Again, this is something that is done only in very few centers in the world, but the concept that you have to keep in mind is that each patient is different from another. And patients with type 1 diabetes, because they have a different mechanism of destruction of beta cells, also reflect that into the potential immunosuppression you have to give. A patient that has a very strong autoimmune response that destroys the beta cells have a strong immune mechanism dealing with the beta cell destruction. So even when you transplant beta cells, you need to keep in account that you restore a sort of autoimmune response towards the transplanted beta cells. So you need to investigate that well. So I think that even for transplantation, the heterogeneity counts a lot. Now, talking about the heterogeneity, I think that the most important condition that has to be taken into account is LADA, the latent autoimmune diabetes in adults. And that is the functional beta cells in LADA compared to type 1 diabetes, classical type 1 diabetes. And as you can see, the heterogeneity of LADA compared to classical type 1 diabetes is even higher. And that could explain the potential treatment with different drugs in patients that have an autoimmune diabetes, but is adult diagnosed and is definitely associated with more insulin-producing cells available. So again, when you take into account intervention and for an adjunctive therapies in LADA, you have to keep in mind that LADA is different in terms of beta cell destruction from classical type 1 diabetes. Now, what are the immunotherapies for LADA? I think that, as I said, because still there are beta cell functioning, the LADA represents the best condition of type 1 diabetes where you can intervene with adjunctive therapies. Then, because there is a slower decline of pancreatic beta cell function, and therefore a number of immunomodulatory therapies can be taken into account by tackling CD4, CD8, the dendritic cells, the macrophages, and then also by intervening with other drugs, including also the DPP4 inhibitor, the GAD65 to induce tolerance, and so on. And in this review, you have a lot of information about these potential immunotherapies for LADA. And what about the role of adjunctive therapy with hypoglycemic agents? So if LADA is a type 1 diabetes in adult, can we use hypoglycemic agents that are used for type 2 diabetes in type 1 LADA? The answer is yes. For metformin, the results are inconclusive. For thiazolidine, there is data that shows some potential effect by reducing glycated hemoglobin. Sulfonylureas definitely are not recommended in these adult patients with LADA because they speed up the destruction of beta cells. The DPP4 inhibitors, peptidase inhibitor, definitely have a potential effect on the metabolic and on the immunological mechanism. And indeed, we published a paper with one of these DPP4 inhibitors, this one that is one of the DPP4 inhibitor available, that is saxagliptin. And saxagliptin was effective in protecting beta cells and having a better metabolic control in patients with LADA. The SGLT2 have been potentially effective, as has been also demonstrated in some studies. And the GLP-1 receptor agonist potentially effective, in particular in patients with overweight or obesity. This is the treatment, the management related to autoimmune diabetes in adults, a consensus statement from International Expert Panel. We published that in 2020. And this is the author of this paper. Tina Tuomi was the first to show LADA in 1993. So this paper was taken by the American Diabetes Association to then adopt the guidelines that were published in 2022 in diabetes following our suggestion. And this is what we can do when you think about LADA and the screening for GAD antibodies to detect patients affected by LADA. And if a negative, these are type 2 diabetes. And if you suspect that also in this population, you have a potential autoimmune response, you have to screen for this specific tyrosine antibodies that are the more specific for LADA. You measure the serum and plasma C-peptide, and this is a crucial value. If C-peptide is less than 0.3 nanomolar, here you definitely need insulin. If you are here, you could actually consider the potential role of different drugs to give to patients with basal insulin. And if they are here with C-peptide, you can apply the type 2 diabetes guidelines, but keeping in mind that the patient had GAD antibodies. So you have to follow this patient that got with the C-peptide greater than 0.7 to avoid that you actually get into a reduction of C-peptide, and then patient probably needs some insulin. So this is what you can read in this paper in diabetes, but I think you could look into here and you can see that both GLP-1 array, SGLT2, and basal insulin in combination can be given to this patient. And then if HbA1c is not a target, then you can give insulin basal bolus therapy. And if the patient has heart failure or chronic kidney disease, of course, the SGLT2 could be given, although there are patients with type 1 diabetes, but because these are patients that have residual beta cell function, it's not like the classical type 1 where you can have problem with ketoacidosis. So then these drugs can be given also in patients that have LADA. Now, in patients that have a C-peptide between 0.3 and less than 0.7 without cardiovascular kidney disease, this is what you should consider. And you have the DPP-4, the GLP-1 array, the SGLT2, and TZDs are all fine to be given to patients with LADA. And you have this way to consider HbA1c as the value that you should keep in mind to decide what therapy give to your patient, from basal insulin or GLP-1 or SGLT2 to basal insulin or SGLT2 at this level. And again, if SGLT2, if HbA1c is above target, you give basal insulin. And if TZD doesn't work and the HbA1c is above target, you can move to DPP-4, GLP-1 array, or SGLT2. And at the end, if patient failing to alter these therapies, you could give insulin basal bolus like a classical type 1. Now, another interesting work is the potential use of GLP-1 array for treatment in patients that are obese and have GAD positive. The SURPASS study has shown that tirzepatide was associated with substantial reduction in HbA1c, as you can see here, and body weight, irrespective of GADA status. So I think that in patients with type 2 diabetes, also those with GADA, could be treated with tirzepatide. And this is a very important paper that was published in JCM last year. And show some very, very interesting results, in particular because tirzepatide is now a drug available and can be given to these patients. Now, this is the other study that I mentioned before, the saxagliptin and dapagliflozin, that was non-inferior to insulin glargine in terms of beta cell function in subject with LADA, the one that I mentioned before. And as you can see, saxa-dapagliflozin, so the combination of saxagliptin with dapagliflozin versus glargine was indeed capable to have similar non-inferiority, similar control, and at 12 months was closer to, was significant, and suggesting that the combination of saxa-dapa could be a good combination in patients with LADA. And again, combination of patients with LADA, combination therapy in patients with LADA without insulin, but insulin is always behind, ready to be given at least a basal insulin if patients have poor metabolic control. So this was the results at 12 months of this study. Weight loss was greater with saxagliptin and dapagliflozin with no difference in glycemic control or hypoglycemic risk. So in conclusion, dear colleagues, ladies and gentlemen, first of all, the concept of endotype in type 1 diabetes suggests that immune intervention implemented at diagnosis and in pre-diabetic phase should be designed accordingly. There is no drug for intervention that fits all. The one-weekly insulin type 1 diabetes offered a real alternative to daily insulin with modest differences in glycemic control and notably safety consideration. And I can tell you that we treat patients with type 1 diabetes and type 2 with weekly insulin. And I can say that patients are very pleased indeed to be treated with weekly insulin. They think that is a major step forward in the treatment of their disease. This is particularly true in patients that have a long-lasting diabetes, where they've been treated with insulin for long. The weekly insulin definitely presents advantages in patient adherence, as I said, and especially because increased risk of infection, site reaction are reduced, and also nocturnal hypoglycemia could be reduced. Then finally, the new interesting agents on clinical trial that I've described to intervene in different disease processes could be very interesting because they could tackle the mechanism that involve in beta cell destruction. So the take-home message that I'd like to give you is that we have a new era for type 1 diabetes prevention and treatment is on its way. And I'm very positive that we will see in the next future that type 1 diabetes will develop less complication because they will have better metabolic control. We have better opportunity to control glycated hemoglobin with this new therapy and prevent the beta cell function that could be important to avoid developmental complication. Thank you very much for your attention. Hello and good day. I'm Professor Pozzilli, and I'm very pleased to discuss with you the type 1 diabetes in the 21st century, innovation, challenges, and the road ahead. Thank you very much for inviting me, Mustafa. It is a great pleasure to give you a talk, but I'm very sorry that I could not come in person. The recent story, I think, began 12 years ago. Type 1 diabetes has been considered always as very standard disease, destruction of beta cells and onset of diabetes and requirement of insulin for the rest of your life. Disease of the childhood, never think a disease of the adult people. So type 1 diabetes was straightforward, a disease characterized by loss of beta cells. But now I think the new word heterogeneity came into action. Is that concept that I'm going to explain you could find the way to intervene early in the natural history of the disease and try to prevent the late complication by preserving the function of the beta cells. And this is something new in terms of natural history of the disease. And what is important is the age at which the disease is diagnosed that make the difference. And I'm going to go through this concept with you today. For type 1 diabetes, a number of traits like clinical phenotype, age of onset, genetic background, and the pathogenesis distinguish the disease. A new concept that has been recently discovered is that type 1 diabetes is also associated by insulin resistance. That is typical of type 2 diabetes. And that finding is associated with overweight, obesity, or type 2 diabetes. Type 1 diabetes and type 2 diabetes together were never thought to exist. But now I think that in terms of pathogenesis, several mechanisms may operate both for type 1 and for type 2 diabetes. In this context, the 2022 American Diabetes Guidelines introduced for the first time the term LADA, latent autoimmune diabetes in adults, suggesting that LADA is a form of type 1 diabetes, but also a type 2 diabetes because initially it does not require insulin and can be treated with oral hypoglycemic agents. I'm going to discuss with you this new concept regarding type 1 diabetes at different ages and the heterogeneity of the disease. This concept should not be confused with other causes of insulin deficiency, like monogenic diabetes or checkpoint-related diabetes or rare monogenic causes. Heterogeneity of type 1 diabetes refers only to clinical, immunological, metabolic, and pathological heterogeneity of the disease in subjects that have classical type 1 diabetes because they need insulin from the beginning of at the time of diagnosis. Now, why the single disease approach is untenable? The reason is that we have different phenotype as well of type 1 diabetes, from phenotype to endotypes. This is a new concept that say that the mechanism leading to type 1 diabetes in the young and lean person and the type 1 diabetes developed in the adult that is overweight or obese may vary. And accordingly, if we want to intervene in this patient to prevent the disease or to treat the disease, we have different approaches. And I think this is an important new concept. And this is what we published last year about the new vision of type 1 diabetes based on endotypes. We define 6 different endotypes for type 1 diabetes. The type 1DE1, the TD1, is the age of onset prepubertal, pubertal, very young patients that are before puberty diagnosed with type 1, the classical type 1 diabetes in childhood. Then type 1 diabetes could have an onset in the young adults, so between the age of 12 and the age of 18. This is the TIDE2 during the late phase of puberty. The TIDE3 are the young patients around the age of 20 up to the age of 30. Then we have the adult, typical adult TIDE4 and TIDE5. That is the LADA group about the age of 30 up to the age of 60. And these are the typical LADA. And then there is a form of diabetes that was quite prevalent during COVID. That is the type 1 diabetes induced by COVID that caused beta cell destruction, but regeneration of the cells because the disease was not genetically predisposed. And this is something that now has disappeared. But it is interesting that a viral infection could damage the beta cells like COVID infection and cause beta cell destruction that could be physiologically regenerated. If we look at the different TIDE according to the HLA, this group, the typical young, has a high HLA genetic susceptibility that tend to decline with time. And so in the adults, you have less genetic predisposition to type 1 diabetes. And if you look at the immunological features, you have that the very young has a lot of autoantibodies at high titer, whereas the other TIDE tend to have less autoantibodies. As you know, there are 4 autoantibodies in type 1 diabetes: the GAD antibodies, the protein phosphatase antibodies, the tyrosine phosphatase antibodies, and the zinc T8 autoantibodies. So these antibodies that are prevalent in the very young tend to be reduced later on with the onset of diabetes in adult life. And the other important concept is the C-peptide. The C-peptide is very low at diagnosis in the very young and tend to be higher in patients diagnosed in adult age, suggesting that in this group of patients, intervention to prevent further destruction of beta cells is very important. And the BMI, the concept that I expressed to you before, is that BMI was very low in the very early onset and tend to be higher later on. And in the adults, this patient could be overweight or obese. Now, based on this concept of stages of the disease and endotypes, what are the therapeutic targets and the challenges of immunotherapy in type 1 diabetes? We can intervene at stage 1, we can intervene at stage 2 of prediabetes, and we can intervene at stage 3. And this, of course, is related to different stage of beta cell destruction. So by intervening in this phase, we can actually try to prevent full destruction of beta cells. And if we intervene later, when we have dysglycemia already diagnosed with early diagnosis of type 1 diabetes, we may have other approaches to try to prevent the further destruction of the remaining beta cells. Regarding the mode of action of different immunotherapies for type 1 diabetes, we have the different concepts that are then here expressed. The antigen-independent strategies, the typical immunomodulation, the antigen-dependent strategies, that is specific immunotherapies, the concept is to induce tolerance to beta cell antigens, and beta cell therapies to protect the residual beta cell and possibly favoring regeneration of beta cell, and the stem cell therapies for the beta cell regeneration could be the final stages for new approaches for immunotherapies in these patients. And we start with the antigen-independent immunotherapeutic strategies. And here you have different strategies, starting from the antibody-based therapies to pro-inflammatory cytokine therapies to TREG, T regulatory cells mediated therapy. And then the therapeutic approach vary, but then we, as you can see, the concept is that each of these strategy is characterized by some action that block the immune checkpoints, you neutralize the cytokines that are involved in inflammation, and you expand the T cell that regulate the immune tolerance. And this is how the mechanism works: inhibit T cell activation, reduce inflammation, or enhance immune regulation. And the key example of drugs that have an action at different level are here represented, from the abatacept and the teplizumab, and these are anti-CD3, and then other drugs that have an effect of reducing inflammation, and the low dose IL-2 and the polyclonal TREG T regulatory cell therapy. The challenges, we have challenges to take into account that are not of low relevance, from the adverse events, the high cost, immunorelated, risk of infection, inconsistent efficacy in some patients, and so on. Now, what is the antigen-dependent immunotherapy? So the concept here is that you intervene by having an effect on one or two specific autoantigens involved in the process of beta cell destruction. As you can see here, the strategies are linked to autoantigenic peptides and protein that are actually the autoantigen versus which the immune response is involved. Autoantigen encoding plasmid DNA, antigen-loaded cell-based therapy, and antigen-loaded nanoparticles and liposome. What are these mechanisms for? To induce tolerance to the autoantigen, and by inducing tolerance, you have an increase of T regulatory cells, and you block the action of autoreactive T cells. So antigen presenting cells that are really inhibiting their action, and of course that could reduce the autoimmune response. These are the advantages and disadvantages. As you can see, there are several advantages and disadvantages, and of course this depends very much what drug you're going to use, considering, as I told you at the beginning, the age of onset of the disease. Because even for trials in phase 2 and phase 3, you have to consider that if you want to intervene in subject with the Tide 1 or Tide 2, that is in the young people, is different compared to the intervention you do in adult patients, where you can be very tough in intervening, and maybe you can do immunosuppression without the problems you can have in children and in adults. These are the novel antigen-independent immunotherapeutic strategies for type 1 diabetes. And as you can see here, there are other interesting therapy types, from the JAK-STAT pathway inhibition to reduce autoimmune activity, to the beta cell preservation to reduce modulating immune responses and reduce inflammation. And by doing so, you tend to preserve the residual beta cells. By inhibiting GLUT1 to reduce the glycolysis in autoreactive T cells, and therefore this should decrease the activity of T cells versus beta cells, and targeting with the SAS modulation for beta cell preservation, the senescence-associated secondary phenotype, also to reduce local inflammation. These are the key advantages and the challenges, and I think this is quite useful to understand what drug take into account, taking into consideration the challenges, because there is the increased infection risk, need for frequent administration and very high cost, long-term safety concern for the GLUT1 inhibition, and complexity in designing therapy risked for unintended side effects. So these are all in phase 2 trials, and there are very few phase 3 trials moving in this direction. Now, and I told you before about the concept of endotypes, and this is something that is the main message you have to take home today. So I remind you about the endotypes, different endotypes, the very young people, type 1 and type 2 endotypes, the type 3 and type 3 endotypes. And of course, they may respond differently to immune intervention. So you cannot expect that one drug may really treat all patients with type 1 diabetes diagnosed at different ages. Now, this is a sum up of the most relevant ongoing therapeutic approaches modulating the autoimmune process in type 1 diabetes. As you can see, this is the antigen-presenting cells. And as you can see, how many T cells are involved here that could be tackled by the drug you want to give. And these are the targets, the islet cell of Langerhans. And so the islet cell of Langerhans, the beta cell, have been infiltrated by macrophages and lymphocytes. And then you can intervene at different levels by reducing the TNF-alpha, by having an effect on IL-6, on IL-23, on IL-12. And the T effector cells, you can try to block the effect of T effector cells. The interferon gamma is another important product that could be involved in damaging the beta cells. And then the result is that apoptosis of beta cells is relevant in this reaction, because by doing an apoptosis of T effector cells, you reduce the damage into the beta cells. And even verapamil, that you remember the calcium antagonist, has been used and has an effect on the beta cells by intervening on the TX and IP. So I think that this concept can offer the opportunity to realize where we stand and how important this treatment could be by using different drugs. Teplizumab is the only drug that has been really tested and is an anti-CD3 monoclonal antibody, and in Italy has been approved and is available for treating patients that are in the very early stage of the disease, even for prevention. And of course, this is an important step forward for treating type 1 diabetes. Now look at the teplizumab, as I said, the only one, the monoclonal antibody available at the moment. This is an anti-CD3 tested first of all in first-degree relatives of type 1 diabetes, and this was the pioneering work by Harold et al. In 20. Teplizumab over a period of 60 months can preserve the number of subjects free of type 1 diabetes over the period of 60 months follow-up. So that was good. And then you can see that C-peptide basically is preserved. You preserve the beta cell function compared to placebo. And as you can see, the daily insulin dose that is definitely reduced. These patients are going to be treated with very low insulin dose compared to the placebo. And technically speaking, now with the weekly insulin available, I think that could be a great advantage for this patient that they may have residual beta cell function, because we control the autoimmune response. And by having residual beta cell function, insulin weekly can be probably given. There are trials ongoing now in newly diagnosed with that. And this is a major step forward for patients that are diagnosed early in the natural history of the disease with type 1 diabetes. Now, this is another interesting article that has been recently published in Diabetology by Chantal Mathieu, the AG019 as monotherapy to induce tolerance to proinsulin. And as you can see here, there is a good results in terms of effect on the C-peptide. C-peptide is preserved, and also the mean 2-hour C-peptide, and the C-peptide compared to placebo has an effect that is definitely very significant at 6 months, with an increase of C-peptide of 124% compared to baseline. Again, still the age of 29 on the HbA1c, and as you can see here, is a non-antigen, as I said, specific immunomodulator. Teplizumab is safe and, as I said, well tolerated. And the oral AG019 is an antigen-based immunotherapy, as I said, to reduce tolerance with proinsulin, and also giving an immunomodulation and preserving the potential, the residual beta cell function, and somehow rebalance the islet antigen-specific effector regulatory T cells. Another interesting study recently published, and there is ongoing now in a very extended trial, is the verapamil. Now, continuous use of verapamil in subjects with type 1 diabetes may delay disease progression and lower the insulin requirement for at least 2 years after diagnosis. And it is associated with normalization of some substances. In particular, the most important is the pro-inflammatory IL-21 levels, interleukin 21, which has a strong cytotoxic effect on beta cells. Verapamil works by modulate the thyroidauxin system and promote an antioxidative, anti-apoptotic beta cells and immunomodulatory gene expression profile in human islets. So this benefit and this interesting are lost upon discontinuation, but the treatment is, I think, of interest because it's safe, has been used for a long time. Verapamil has been used for a long time, and you can somehow block the process of beta cell destruction. Further studies are required, and there are ongoing important long-term studies to find out if you can reduce the amount of insulin needed. Because normally a patient with type 1 diabetes, remember, is around 0.7, 0.8 unit kilogram body weight. But if you are treated for the rest of your life with 0.4, 0.5 units kilogram body weight of insulin, it is a small amount of insulin. And definitely your diabetes may be better controlled because you have endogenous insulin release still present. So it's a combination of exogenous insulin plus some endogenous insulin. This is where we are moving forward. And I think this is the future of immunointervention in type 1 diabetes. We did a study published a couple of years ago on the inhibition ladarixin that inhibit another pathway of beta cell destruction in patients with new onset type 1 diabetes, that is the CXCR1, CR2. And these are the results of primary endpoint, the area under the curve of C-peptide. As you can see, there was a slight increase in patients with severe onset in terms of C-peptide. But interesting is the fact that in patients treated with this ladarixin, there was a better HbA1c, as you can see, at 3, 6, and but then was lost later. So an effect that was partial during the first 6 months, but that of course was of interest because it means that the residual beta cell function could have an effect in that protection of beta cells and then glycated hemoglobin that was normalized within the first 6 months. And this is the insulin dose. As you can see, patients that were treated with the ladarixin had a daily insulin requirement that was lower, and suggesting that in patients with severe onset subgroup, this drug was particularly significant in those with type 1, so in children. That is quite interesting. Now I'm going towards another another approach, the pleconazole and ribavirin in onset type 1 diabetes patients. This is a randomized phase 2 trial. These are antiviral drugs, and considering the drug that could somehow have an effect antiviral, although we don't know if there is a specific virus. So far, only coxsackie before were found to be toxic to beta cells. Anyway, this treatment show a modest effect, but could offer a rationale for combination therapy with other drugs to evaluate the use of these antiviral drugs that are safe in terms of adverse effects, and so could be reconsidered in the light of this preliminary data. So in conclusion, dear colleagues, ladies and gentlemen, the type for immunotherapy in type 1 diabetes started over 40 years ago with nearly 40 years ago with cyclosporine. And since then, hundreds of trials have been carried out, but without significant results. We learn about the natural history of the disease, and that has been an important concept because that really opened the way by separating patients diagnosed with type 1 diabetes among those pre-pubertal and those post-puberty. And therefore, this could be an important concept to take home today for you. Patients with type 1 diabetes are very heterogeneous. And being very heterogeneous, we cannot consider that type 1 diabetes is a unique disease that has to be treated for prevention in the same way. And so novel and old drugs that tackle different mechanisms are currently being tested. And if you go to Innodia website, you can find that there are really 30, 40, 50 different trials ongoing at the moment. And it's important when you define a trial and when you participate, if we are invited to take part in a trial, to select carefully the population of type 1 diabetes that have that characteristics in terms of pathogenesis that could be the characteristics that are tackled by the drug or by the approach you have in mind to use. So you have patient characteristics, and after patient characteristic, considering the drug for trials, you have to take into account how this patient behave in terms of evolution from the beginning of the disease that has been in pre-pubertal, post-pubertal, and after, and in the adult age. So I conclude with these slides that Italy is the first country that approved in September 2024, 1 year ago, a law for the evaluation of GAD and transglutaminase antibodies in the general population to identify subject risk for type 1 diabetes and celiac disease. This is the first country that approved this, and so this is reimbursed by the National Health Service. And by doing that, we can identify that those subjects that are at risk for developing the disease. And of course, this could be the next step. We identify those that are GAD positive, tyrosine phosphatase positive, or only 2 or 3 autoantibodies, and therefore we may decide what type of intervention could be tested in this population. And that means prevention of the disease could be somehow possible, and we look forward to the results in the next coming years. Thank you very much for your attention.